This PowerPoint is an overview and supplement to Chapter 22, Avoidance of Complications in Neurosurgery, in Yeoman's and Wynne 8th edition. This chapter covers a broad range of topics and goes into detail over many of the risks and pitfalls inherent in challenging surgical procedures and how to avoid them. But it covers too many diverse surgeries to review in this presentation. Some of the main common points, though, are that avoidance of complications in neurosurgery is as important as the treatment of disease. Complications in neurosurgery can arise from the unique disease processes we encounter, the delicate anatomy, and the challenging surgical approaches we see. Complications can be minimized by selection of appropriate patients, surgical treatments, surgical approaches, surgical positioning, and postoperative care. Anticipating possible complications encountered at each step of treatment allows the neurosurgeon to minimize the risk to the patient. And attention to immediate preservation of neurologic function, as well as to long-term overall patient functionality, leads to the best outcomes. The two newest additions to our complication avoidance toolbox since the last publication of the text are the advances in technology, such as intraoperative imaging, navigation, robotics, augmented reality, and artificial intelligence, which are designed to help reduce the risk of complications. But in addition, there's an entirely new topic that's come front and center in surgery, and that's the subject of the implementation of safety protocols, which have become commonplace and are intended to increase safety and decrease complications. The notion of protocolizing medical care really took hold after the publication of this seminal piece by the Institute of Medicine, To Err is Human. It was published in 1999, and it really set the path which led to the implementation of surgical safety checklists and protocols. Basically, this publication concluded that there are 100,000 deaths per year in U.S. hospitals due to preventable medical error. This number has been quoted ever since. The actual numbers and the methodology of this study have been challenged, but ultimately, this study is what formed the basis for the push for checklists and standardization within medicine. Following this, another important study came out of an Israeli ICU and was published in 2003. This was a human engineering study. Again, it was published out of an Israeli ICU, where they observed the activities each day. And it was found that an average of 178 activities or interactions took place per patient per day. And there were 1.7 errors per patient per day. So overall in the ICU, severe or potentially detrimental errors occurred twice a day, every day. The idea of preventable errors and checklists outside of medicine had been around for quite a while. We all know about checklists in aviation. This really started in 1935 after Boeing introduced its new model, the Model 299, and it was tested by the United States' most experienced fighter pilots. This test flight resulted in a crash after just a few seconds, which killed the pilot and one of the crew members. The investigation that followed revealed that there were no mechanical failures, that this was the result of a pilot error. Keep in mind that the pilot, the co-pilot, and all of the crew members were the most experienced fighter pilots that the U.S. Army had. But what took place was that there was a new safety feature introduced, and it was meant to be disengaged prior to takeoff. The pilot, the co-pilot, and the Boeing chief test pilot, who was also on the flight, all forgot to disengage the safety feature. At the conclusion of the investigation, the U.S. Army Air Corps chief of flight testing concluded that this was simply too much airplane for one man to fly. In other words, flying airplanes had simply become too complicated to rely on one person to remember every step that needs to be performed in every different airplane that they'll fly. So checklists were introduced, a checklist for takeoff, flight, landing, and taxiing. And these enabled pilots to fly nearly 2 million miles in what became the B-17. they flew these miles without a single accident, and it was used in the successful U.S. bombing campaign against Nazi Germany in World War II, again without a single accident as a result of these checklists. Now, after the next major contribution was the Keystone Initiative, which really defined and studied the science of healthcare delivery. This was led by Dr. Peter Pronovost in a Detroit ICU, and it was a quality improvement initiative, the same kind of quality improvement initiative that many of us undertake in our own institutions. He linked safety science to healthcare delivery and published a landmark New England Journal of Medicine paper in 2006. And here are the findings. They found that central venous catheter infections were causing a disproportionate number of deaths in the Detroit ICU. Dr. Pronovost instituted a 5-point checklist protocol. As a result of this protocol, infection rates in the ICU dropped 66%, and this was a sustained drop over 4 years. It's estimated that 1,500 lives were saved and $175 million were saved in the first 18 months that this protocol was instituted, and these results have been sustained to date. After this project was published, it really began to change the conversation about patient safety for doctors, patients, legislators, and payers, insurance companies. And here's the 5-point checklist, which was so impactful. As you can see, it's quite simple, but it was met with resistance initially because physicians felt these basics were already covered. But once the metrics were truly applied, adherence increased and outcomes improved. The idea of patient safety really became part of the public conversation with Atul Gawande. He was able to reach the lay public through his publications in the New Yorker. And he helped promote the idea of standardization of medicine. He pushed for safety checklists, and he pushed for a team's approach versus a captain of the ship approach. So surgical safety checklists are here to stay. We all are familiar with the timeout prior to beginning surgery. We all check off boxes on checklists prior to bringing patients into the operating room. But the question is really, how do we apply surgical safety checklists to our neurosurgical procedures? You can see that most of the safety checklists are very simple, and they deal with one specific branch point or one specific aspect of a procedure, and they break it down into its simplest steps. But neurosurgery is very complex. We perform many different surgeries with many steps. There are many decision branch points and many different patient characteristics that we deal with. We can't create a single checklist that will account for every step of every type of procedure on every type of patient, pre-op, intraoperative, and post-operative. So we have to focus on the simplest aspects of care and get them right. This is the low-hanging fruit philosophy. And we know that standardization can help and that checklists can help. So currently, most neurosurgical safety checklists resemble other specialties' surgical checklists. We focus on wrong site error. We focus on positioning complications. We focus on failure of devices required for the procedure, fluoroscopy, navigation, microscopes, endoscopes, drills, etc. But really, to date, only a few neurosurgical centers have published on procedure-specific checklists. This requires a big cultural shift within neurosurgery and buy-in of all the stakeholders, all the participants. When the next edition of Yeomans and Wind is published in a few years, I expect there'll be many more publications specific to neurosurgery that will be reviewed in this talk. Thank you.